Welcome to the deep dive. Today we're tackling a really fundamental area for those of you entering nursing, how certain medications impact the male reproductive system. We've gathered a wealth of information looking at everything from androgens and, anabolic steroids to the drugs used to treat erectile dysfunction. Our mission today is to, distill this down to the core knowledge you need for practice.
That's exactly it. This isn't just about memorizing drug names. It's really about understanding the underlying mechanisms, why these drugs are used, and critically, what you need to watch out for as a healthcare provider. Patient safety and well-being.
Okay, let's dive straight into androgens then. Yeah. We know testosterone is the primary male sex hormone, right? Mostly from the testes, a bit from the adrenal glands. But what exactly are these androgens in charge of?
Well, think of androgens, especially testosterone, as sort of the conductors of male development. They orchestrate those physical changes we see, during puberty, the deepening voice, hair growth, maturation of genitals, all that stuff.
So driving those key male characteristics.
Exactly.
But it's more than just the outward changes, isn't it? I'm seeing notes here about how they affect things like nitrogen balance. And electrolytes.
Absolutely. Yeah. Beyond sexual development, androgens have these really important metabolic roles.
Okay.
Think of them as helping the body kind of hold on to key building blocks, like nitrogen for muscle.
Right. Muscle growth.
Yeah. And influencing electrolyte balance, sodium, potassium, phosphorus. They also play a role in reducing calcium loss through urine. And what's fascinating is their impact on protein metabolism. They boost protein creation, slow down the breakdown.
Anabolism versus catabolism.
Precisely. And crucially, they stimulate red blood cell production. That's something to really keep in mind, when assessing patients on these therapies for potential issues like fluid retention or electrolyte imbalances.
Got it. So knowing all that, what are the main medical reasons we'd actually prescribe androgen medications?
Well, the most common reason is definitely replacement therapy for men with hypogonadism.
Okay, when the testes aren't producing enough testosterone.
Exactly. Could be from various underlying conditions. We also see androgens used sometimes in treating specific types of breast cancer.
Breast cancer, interesting.
And then there's Danazol. It's a synthetic androgen, and it has some unique applications, actually, in women.
In women? Okay, like what?
For conditions like endometriosis, fibrocystic breast disease, and also something called hereditary angioedema.
Wow, okay. Danazol for those female conditions, that feels a bit unexpected. How does a male-like hormone help with those issues?
Yeah, it's a great question. It really highlights how interconnected our hormonal systems are. So in women, Danazol actually works by sort of quieting down the communication between the hypothalamus, pituitary gland, and adrenal glands, the HPA axis.
Oh, that communication network.
Right. It links the brain to the hormone glands. Danazol also reduces the release of GnRH.
Gonadotropin-releasing hormone.
Yep. Which in turn lowers levels of FSH and LH, key players in the female cycle and those related conditions.
Okay. So by influencing that central control system.
Exactly. It can have therapeutic effects on these, seemingly unrelated conditions.
Okay. That makes the connection much clearer. Now let's talk about anabolic steroids. How are these different from the androgens we've been discussing?
So anabolic steroids are essentially tweaked versions, analogs of testosterone.
Okay.
Scientists modified the molecule to enhance its muscle-building effects, the anabolic part, while trying to minimize the more traditionally male characteristics, the androgenic effects. But, and this is really important, these two types of effects are often linked. You don't always get one without the other.
Right. You can't completely separate them. So if the primary goal is tissue building, what are the typical medical uses for anabolic steroids?
Okay, so we use them to treat certain types of anemias. Some specific cancers, angioedema, as we mentioned. They can also be helpful in promoting weight gain and tissue repair in patients who are, significantly weakened, maybe after a major illness or surgery.
Debilitated patients.
Exactly. And for patients on long-term corticosteroid therapy, which can unfortunately lead to muscle-wasting anabolic steroids, can help promote protein building, counteract that a bit.
This brings up a really important area for us as future nurses. How do we think about using these drugs across the lifespan? What are some key things for different age groups?
Oh, this is absolutely critical. You really have to tailor your approach. In children, for instance, androgens or anabolic steroids might be used for hormone replacement or maybe to stimulate red blood cell production in kids with kidney failure.
Okay.
But because these hormones can significantly impact bone growth, we have to monitor these young patients very, very closely. We need x-rays of their hands and wrists before treatment and then every 6 months during.
Wow, every 6 months.
Yes. And if we see any signs of early puberty, precocious puberty, the medication needs to be stopped right away. It can cause the growth plates in their bones to close too early.
Right, affecting their final height. Okay, and what about teenagers? This seems like a particularly important group given, societal pressures in sports.
Exactly. Adolescents on these meds, they should be told about the potential for increased acne. That's common.
Yeah. Mm-hmm.
And yes, given the intense pressures around athletic performance, it's absolutely our responsibility to educate young athletes about the very real risks of using anabolic steroids to try and, get an edge.
Yeah.
It's vital to emphasize that there's really a lack of strong scientific evidence showing they actually provide a significant sustainable benefit to performance.
Mm.
And the potential downsides can be really severe. We need to acknowledge those pressures, but be clear about the lack of proven benefit.
That's a key counseling point. And when we move into adulthood?
Well, for adults, the education about the dangers of using anabolic steroids for athletic enhancement just needs to continue. It's an ongoing issue.
Right.
For women who are prescribed these drugs for legitimate medical reasons, it's important to prepare them for potential masculinizing side effects, voice changes, hair growth, stuff like that, and offer support.
Okay.
Men on testosterone replacement might need clear instructions, maybe support, on how to self-administer injections or use the topical forms like gels or patches properly.
Practical skills.
Yes. And across all adult age groups receiving these medications, regular monitoring of liver function is essential. These drugs can be tough on the liver.
What about during pregnancy and breastfeeding? That seems like a definite no-go period.
Absolutely contraindicated, 100%. There's a significant risk of serious harm to the developing fetus or the breastfeeding infant, no question.
Okay. And our older adult patients, they often have a number of pre-existing health conditions we need to be mindful of.
Precisely. Older adults can be more susceptible to the adverse effects, things like hypertension, heart failure, coronary artery disease. These can be aggravated by the fluid retention these drugs sometimes cause.
Makes sense.
Benign prostatic hypertrophy, BPH, which is common in older men, can also worsen due to the androgenic effects.
All right.
That can lead to increased urinary problems.
Right.
Plus, liver function can naturally decline with age, and these drugs can be hepatotoxic. So very careful monitoring, potential dose adjustments are crucial. Watch for signs like jaundice, fatigue. The drug might need to be stopped.
So a key takeaway, always diligently review a patient's history for those pre-existing conditions before starting these meds.
Absolutely essential.
And we really can't discuss anabolic steroids without acknowledging their widespread illegal use for athletic performance enhancement. It's a huge issue.
It really is a major public health concern. They're misused by individuals hoping to build muscle mass, increase red blood cells, and, they believe, enhance strength and endurance.
Right.
But it's critical for everyone, especially future healthcare professionals, to understand these are Class 3 controlled substances. High potential for abuse, risk of serious health consequences, especially with the high doses and stacking often seen in non-medical use.
Okay. Let's delve a bit into how these drugs actually behave in the body, their pharmacokinetics.
Sure. So testosterone itself comes in various forms, right? Each affects absorption and duration. We've got depot injections for sustained release.
The long-acting ones.
Yeah. Buccal tablets that dissolve in the cheek, topical gels, sprays, patches, even little pellets implanted under the skin.
Lots of options.
And then oral synthetic androgens like Danazol or methyltestosterone have their own profiles. Generally, though, androgens are absorbed fairly well. They distribute widely in the body, get metabolized mainly by the liver, and then excreted in the urine. We're not entirely sure if they pass into breast milk. The data is incomplete.
Okay. And for anabolic steroids, how are they typically processed?
Anabolic steroids are usually taken orally. Similar to androgens, they're generally well absorbed from the GI tract, distribute widely, undergo significant liver metabolism, and are excreted in the urine. As we said, contraindicated in pregnancy. And while we lack definitive data on breast milk, the standard advice is alternative feeding if the mother needs these meds. Just too risky.
Safety first.
Yes.
Always. What are some key contraindications in situations where we need to be particularly cautious?
Okay, well, a known allergy is obvious.
Of course.
Pregnancy and lactation, we've covered absolute contraindications. In men with prostate or breast cancer, these drugs are generally avoided. They could potentially fuel growth.
Hormone-sensitive cancer?
Exactly. We need significant caution with pre-existing liver dysfunction or cardiovascular disease that can worsen these.
Right.
And there are box warnings. Topical testosterone products have one about virilization risk in children.
Development of male characteristics from contact?
Yeah, skin-to-skin contact, contaminated clothing. So meticulous hygiene, covering the application site, crucial patient education. Danazol also has a boxed warning. Risk of serious blood clots, thromboembolic events, fetal abnormalities if taken during pregnancy, liver problems, and intracranial hypertension, which is increased pressure in the skull.
Wow.
And it's not meant for long-term use because of these risks.
Good to know. Let's get into the potential adverse effects. It sounds like there's a considerable list here.
There certainly is a range. The androgenic effects from the increased male hormone activity can include things like acne, edema, or swelling from fluid retention, increased male pattern hair growth, hirsutism, deepening voice, oily skin and hair, weight gain, decreased breast size, penile enlargement, and testicular atrophy or shrinkage.
Okay.
In boys who haven't hit puberty yet, we can see virilization, phallic enlargement, hirsutism, more skin pigmentation.
And in adult males.
In postpubescent males, these drugs can actually suppress normal testicular function. That can lead to gynecomastia, breast enlargement, testicular atrophy, priapism, which is prolonged painful erections.
Right.
Male pattern baldness, and changes in libido up or down. And there's that increased risk of prostate problems, especially in older men.
And what kind of effects might we see in women taking these? You mentioned masculinizing effects earlier.
Yes. In females, because estrogen gets suppressed, we see anti-estrogenic effects. Flushing, sweating, vaginitis, nervousness, irregular periods, or stopping altogether. Hirsutism, clitoral growth, emotional ability can be quite distressing.
I can imagine. Are there other general side effects nurses should look out for?
Yeah. Common stuff includes headache, dizziness, sleep problems, fatigue, rashes, maybe altered electrolytes. More seriously, though, is the potential for life-threatening liver damage.
Hepatocellular cancer, hepatitis.
Exactly, which really underlines why those regular liver function tests are so important. Fluid retention and increased cholesterol can also raise cardiovascular risk. And it's worth noting, inappropriate testosterone use, especially for unapproved things like low T syndrome.
Without proper diagnosis?
Right. It's been linked to serious cardiovascular events, heart attack, stroke, blood clots, like DDT or PE. The FDA has warned about this. And in kids, as we said, premature closure of the bone growth plates. And with excessive or off-label anabolic steroid use, you see even worse things. Cardiomyopathy, liver cancer, significant personality changes, sexual dysfunction. It's a grim picture.
It really is. It's also crucial to think about how these drugs might interact with other medications a patient is taking.
Oh, absolutely critical. Androgens can actually mess with thyroid function tests, making thyroid activity look lower than it is.
Good to know for interpreting labs.
Yes. Yeah. They can also increase creatinine levels and creatinine clearance, and that effect can linger for a couple of weeks after stopping the drug. Importantly, they can alter the effects of oral anticoagulants like warfarin. They might increase sensitivity, meaning a lower warfarin dose is needed to avoid bleeding.
Very important interaction.
Definitely. Similarly, they can affect how the body responds to insulin and oral antidiabetics. Might need dosage adjustments there, too. There's also a potential for increased liver toxicity if used with other hepatotoxic drugs.
Adds up.
And finally, they can affect lipid metabolism, maybe making cholesterol-lowering drugs less effective. So, always check that full medication list for interactions.
Right. Now, we see a lot of products marketed towards athletes, herbal stuff, alternative therapies claiming to boost performance. How do these fit in if a patient is actually on prescribed androgens or steroids?
That's a really relevant point in practice. There's tons of marketing around things like bee pollen, creatine, damiana, spirulina, wild yam, often pitched as natural and safe.
Yeah, the natural label is powerful.
It is. But patients need extreme caution. Often there's just no solid scientific evidence they actually work. Plus, they can cause allergic reactions, interact with prescribed meds, including androgens and steroids, and some might even be toxic themselves.
So unpredictable.
Very. Yeah. Patients prescribed androgens or anabolic steroids for a medical reason should be specifically told to avoid these herbal or alternative therapies. The risk of harmful interactions is just too high.
Okay, sound advice. Let's transition now to talking about drugs used for penile erectile dysfunction, or PE. Can you just briefly explain the basic physiology there?
Sure. In essence, PED happens when the spongy tissues in the penis, the corpus cavernosum, don't fill with enough blood to get or keep an erection firm enough for, satisfactory sexual activity.
Okay.
It can stem from lots of things. Aging is a factor, but also underlying medical conditions affecting blood vessels, that's vascular issues, or the nerves involved, neurological issues.
Got it. And what are the primary types of medications we use to treat PED?
So the main pharmacologic treatments fall into two categories. There's prostaglandin E1, which is alprostadil.
Okay.
And then a class called phosphodiesterase type 5 receptor inhibitors, or PDE5 inhibitors. That class includes common ones like Evanafil, Sildenafil, Tadalafil, and Vardenafil.
Right, the Axivils. How do these two different types of drugs actually work to help with an erection?
Okay, so alprostadil works locally. It's either injected right into the corpus cavernosum or inserted as a tiny suppository into the urethra.
Direct application.
Yes. Its main effect is relaxing the smooth muscle in the penile blood vessels. That relaxation lets more blood flow in, causing engorgement and erection.
Okay. And the PDE5 inhibitors, they're oral, right?
Right, they're pills. They work by boosting the effects of nitric oxide in the corpus cavernosum. Nitric oxide naturally triggers the production of another molecule, cGMP.
cGMP.
Yeah, cyclic GMP. That's what actually relaxes the smooth muscles and increases blood flow. PDE5 inhibitors block the enzyme phosphodiesterase type 5 that normally breaks down cGMP.
Yeah, so they keep cGMP levels higher for longer.
Exactly, which prolongs the muscle relaxation and promotes the blood flow needed for an erection. Interestingly, Sildenafil, under the brand name Revasio, and Tadalafil, as Adcirca or Alic, are also used for pulmonary arterial hypertension.
Oh, right, by relaxing smooth muscle in the lung arteries.
Precisely. And Vardenafil also comes in a form that dissolves quickly in the mouth.
So different routes, slightly different mechanisms. What about how the body handles them, their pharmacokinetics?
Okay. Alprostadil, when it's injected or inserted, gets metabolized really quickly, mostly in the lungs, to inactive stuff, then excreted in urine.
Fast-acting, fast breakdown.
Pretty much. The PDE5 inhibitors, being oral, are generally well absorbed. They get metabolized in the liver, and the inactive metabolites are mainly eliminated in the feces.
Okay.
An important difference among them is their onset and duration. Sildenafil and Vardenafil usually start working in about, say, 25 to 30 minutes and last around 4 hours.
So take about an hour before needed.
Typically, yeah. Tadalafil is a bit slower to start, maybe 35 minutes, but it lasts much longer, up to 36 hours. That's why it gets called the weekend pill.
Ah, right.
And Evanafil tends to be the quickest, maybe 15, 30 minutes onset, but shorter duration, maybe 2-3 hours.
Good to know those differences. We briefly mentioned pulmonary hypertension. What about using these drugs in women or during pregnancy and breastfeeding?
Right. So while the main indication is PED in men, some PDE5s are used for pulmonary hypertension in both sexes. For female sexual dysfunction, though, they're generally not indicated. For pregnancy and lactation, the usual advice applies. Only if there's a clear medical need and the benefits outweigh potential risks. Because we don't fully know alprostadil's effects on pregnancy, men using it should use condoms if their partner is pregnant.
Safety precaution.
Okay.
What are the key contraindications and precautions for PED meds?
For both types, alprostadil and PDE5 inhibitors, they're contraindicated if someone has an anatomical abnormality of the penis or conditions that might predispose them to priapism, that prolonged erection risk.
Makes sense.
Alprostadil specifically shouldn't be used by men with penile implants. And generally, these aren't for women looking to improve sexual performance, except for the pulmonary hypertension uses we mentioned.
Right.
With PDE5 inhibitors, we need caution in patients with bleeding disorders, coronary artery disease, active peptic ulcers, retinitis pigmentosa, a genetic eye issue, optic neuropathy, also hypotension or severe hypertension, congenital prolonged QT interval, or significant liver or kidney problems. These conditions could potentially be worsened. And then there are those critical drug interactions.
We'll get to those. First, what about common adverse effects?
With alprostadil, it's mostly local effects in the penis. Pain at the injection site, maybe infection risk, priapism, fibrosis or scarring, and rash.
Okay, localized.
The PDE5 inhibitors, being systemic, can cause headache, flushing, also priapism, dyspepsia or indigestion, UTIs, diarrhea, dizziness. Optic neuropathy leading to vision changes, eighth cranial nerve toxicity or sudden hearing loss, which is rare but serious, potentially increased melanoma risk, and rash.
Okay, quite a list systemically.
Yeah.
Now, those drug interactions sound particularly important, especially with heart meds.
Absolutely. This is critical knowledge. PDE5 inhibitors absolutely cannot be combined with organic nitrates.
It's like nitroglycerin isosorbide dinitrate for angina.
Exactly. Combining them can cause a severe, potentially fatal drop in blood pressure. It's an absolute contraindication.
Cannot stress that enough.
Cannot stress it enough. Similarly, they generally shouldn't be used with alpha-adrenergic blockers, sometimes used for high blood pressure or BPH, again, due to the risk of serious hypotension. And then there are interactions with drugs that inhibit a key liver enzyme, CYP3A4.
Like ketoconazole, erythromycin.
Right. Those can increase the levels and effects of the PDE5 inhibitors, raising the risk of side effects. Might need to monitor closely, maybe reduce the PDE5 dose.
Got it.
And certain HIV protease inhibitors like indinavir or ritonavir can also significantly increase vardenafil or tadalafil levels, often requiring a dose limit on the PDE5 inhibitor. Bottom line, know all the patient's medications.
Definitely. There is also a note about grapefruit juice and high-fat meals affecting PDE5 inhibitors.
Yes, important patient teaching points for safe use. Avoid grapefruit juice. It inhibits that same CYP3A4 enzyme.
Ah, like some of those other drugs.
Exactly. So it can increase PDE5 levels, raising side effect or toxicity risk. And that effect lasts a while, maybe 48 hours, so avoid it for a few days around taking the med.
Good tip. And high-fat meals.
Taking the med with or right after a high-fat meal can delay absorption, so it takes longer to start working, which can be frustrating if timing is important.
Right, defeats the purpose sometimes. We also have a prototype summary for Sildenafil, Viagra, key takeaways.
Okay, Sildenafil, primary use, PED with sexual stimulation, also Revascio for pulmonary arterial hypertension.
Yeah.
Mechanism. Inhibits PDE5, boosts nitric oxide, increases CGMP, relaxes smooth muscle, increases blood flow. Erection happens with stimulation.
Got it.
It's oral, onset maybe 15-30 mins, peak 30-120 mins, duration about 4 hours. Liver metabolism excreted in urine and feces. Side effects, headache, vision changes, blurriness, blue tinge maybe, flushing, indigestion, UTI, rash, potential for low blood pressure, priapism, and rarely hearing loss.
Okay, comprehensive. So for nurses caring for patients on TED meds, what are the essential nursing considerations? Sum it up for us.
Right, the nursing process. First, thorough assessment. Check contraindications, cautions, allergies, penile issues, bleeding disorders, ulcers, CV, liver, kidney problems, QT interval. Get that baseline status. Monitor during treatment, skin, neurostatus, vitals, heart sounds, local inspection of using alprostadil. Check relevant labs like bleeding times, liver function.
Nursing conclusions might include things like altered body image, impaired comfort from injections, risk for altered tissue perfusion due to hypotension, risk for knowledge deficit, standard nursing diagnoses. Yeah. Planning focuses on optimal effect, minimal side effects, patient understanding. Interventions include assessing the cause of the dysfunction,
Important.
monitoring patients with vascular disease closely, detailed teaching for alprostadil self-injection, storage, technique, disposal, being super vigilant about the nitrate alpha blocker interactions with PDE5s, and comprehensive patient teaching overall.
And evaluation.
Monitor response, improve direction, watch for adverse effects, dizziness, flushing, local issues, GI upset, priapism, hypotension, vision hearing changes. Evaluate teaching effectiveness, patient comfort, safety, adherence.
Great summary. And finally, what are the absolute key points we must teach patients starting PED treatment?
Okay, need to knows for patients. Understand PED affects erection sexual function. Know their specific drug, alprostadil injection insert, or PDE5 inhibitor, oral pill.
For PDE5s, crucial they understand it helps blood flow with sexual stimulation. It's not automatic.
Key point.
The absolute paramount point. The dangerous, potentially fatal interaction between PDE5 inhibitors and nitrates or alpha blockers. Hammer that home.
Cannot repeat that enough.
Absolutely. Thorough education on side effects, other interactions like grapefruit juice using only as directed by a provider, what to do for priapism, and the need for regular follow-up.
Excellent. This has been an incredibly thorough deep dive into these drugs affecting the male reproductive system. It's so clear how crucial this knowledge is for nurses starting out.
Absolutely. We've covered a lot of ground today, haven't we? From androgens and anabolic steroids, their uses, mechanisms, significant side effects to the PED drugs, and all the critical nursing considerations for both classes.
Yeah, really comprehensive. So as a final thought for you, our listener, think about the impact of societal expectations around masculinity, body image, sexual function. As future nurses, you'll be right there, providing evidence-based info, compassionate care for people navigating these sensitive issues, and the medications involved.
A really important role.
We encourage you to keep exploring the complexities, the ethical dimensions sometimes of hormonal therapies and athletic enhancement, and always, always prioritize patient safety and well-being in your practice. Thanks for joining us for this deep dive.